Welcome to AETCM, the Emergency Medicine channel. Shall we start soon?
Yes.
A 46-year-old male came to ER with complaints of pain and restriction of movements of the right shoulder. On initial 10-second assessment, airway was patent, no pooling of secretions. Breathing SpO2 99 on room air. Respiratory rate was 12. Circulation BP 140 by 80. Heart rate 84 beats per minute. Disability, restriction of range of movements of the right shoulder was present. Exposure afebrile. Pain score was 9 by 10. According to WHO pain management, injection Fenta 30 mcg IV stat was given. On sample history, a patient has no known comorbs. Patient was trying to push a bike manually when he suddenly felt a giveaway feeling in the right shoulder, followed by patient had pain and inability to move his right arm. A local examination of the right shoulder. Local examination of the shoulder. Inspection, first we'll have to take consent for examination. We'll have to expose both the shoulders. We'll have to inspect anteriorly, posteriorly and laterally. On anterior inspection, we'll have to look for contour, symmetry and obvious deformity. Attitude of the right limb was abducted and externally rotated and supported by the other hand. There was loss of contour of...
Like this.
Abducted, external rotated.
Externally rotated.
Knee was, elbow was flexed and supported by the
Like
other
this. Okay.
There was loss of contour of the right shoulder, and when it comes to symmetry, this was on lower side compared to the right was on lower side compared to the left. There was no scars or swellings or abrasions. Coming to in posterior inspection, we'll have to look for winging of scapula.
So what is the abnormality here right now?
Loss of
Inspection
contour.
wise?
Loss of contour is there. When it comes to symmetry,
Contour
contour of the shoulder, right
Okay.
shoulder.
All right. Then
Attitude of the limb was abducted
Okay.
and externally rotated.
anteriorly. Posteriorly?
Posteriorly, no winging of scapula. No abnormalities.
Winging of scapula.
We'll have to look for in inspection. Coming to palpation, there's no tenderness or rise in temperature. Humeral head was palpated anterior to the coracoid process.
Anterior to the coracoid process. Okay, so you should start in palpating from here. Local rise of temperature anyway has to be checked.
All the
And palpation has to be from here itself, including the clavicle.
Clavicle, sternoclavicular joint, acromioclavicular joint,
Then
humeral head,
acromioclavicular joint,
humeral head, scapular
humeral
spine.
head, the greater tuberosity, lesser tuberosity, then posteriorly the acromion, this thing, the
Coracoid process.
Then the muscles, scapula, everything has to be palpated. Also the C-spine also. Okay. Because pain here, something can relate to this aspect also.
Radiation. Coming to range of movements, patient due to pain, patient had
So
difficulty.
anatomy wise, what are the muscles of the
Rotatory cuff. Infraspinatus, supraspinatus, subscapularis, and teres minor.
Okay. All right. And which nerve is involved in that area? In shoulder dislocation.
Axillary nerve is most
Axillary nerve. Which muscle supplied by axillary nerve?
deltoid and teres minor.
Deltoid and teres minor. So, which action?
Deltoid has abduction.
Abduction,
Teres minor external rotation.
external rotation. Okay. Does the axillary nerve have any sensory supply?
Yeah. Lateral shoulder. We can see regimental bad sign.
Regimental
Bad
bad
sign.
sign. Because these are important, because when you have diagnosed a dislocation of the shoulder and you're planning to reduce, before that you should
check for the neurovascular deformity.
things, whether the axillary nerve is all fine, whether the sensation is preserved on the regimental area. Because once you reduce and then when you recheck for the sensation, if sensation is not there and you haven't previously documented it as there is no sensation, there is high chance that the patient will sue you. medico-legal issues are there. So always before reduction or before doing any this thing, always assess the neurovascular status and document.
A range of movements. Due to pain, patient had difficulty doing all the movements. Coming to neurovascular examination, all distal pulses were felt. For axillary artery involvement, we'll have to look for any absence of radial pulse, axillary bruit, axillary hematoma, or bruise. Any bruising should be looked for to rule out axillary artery involvement.
So these are the complications that you expect in a
Axillary artery involvement.
in a shoulder dislocation. Axillary artery involvement, then axillary nerve issue, then
recurrence of dislocation.
then associated fractures.
Humeral head fractures.
Greater trochanter fracture, lesser trochanter fracture. Then even acromioclavicular ligament can be lax. Even if there should be a can be a problem in the glenoid cavity, in the labrum. Injuries can happen. Then what else can happen? Rotator cuff injuries. All these are possibilities. Okay.
Coming to sensations, we'll have to look for any loss of sensation over the lateral side of the shoulder to rule out regiment bad sign positivity. And coming to special test, we'll have to check for Dugas test, Hamilton ruler test, and axillary circumference.
Axillary nerve arises from where?
C5, C6.
C5,
C6.
That means here you have the brachial plexus, right? C5, 6, 7, 8, T1. And it's divided into all the cords and all. On the posterior cord only it's rising. The axillary nerve.
Dugas test is when we'll have to try.
You're talking about what is the next thing?
Special test in dislocations. Dugas test, Hamilton ruler test.
Okay, once a patient came, like patient's hand is in abduction and external rotation and like this, and you gave some analgesics, you stabilized. Now your plan is to
examine the shoulder.
Okay. You're suspecting some shoulder dislocation, but clinically it appears as though patient is having an anterior shoulder dislocation. So what are the other shoulder dislocations?
Posterior and inferior.
In
anterior there are 3 types: subglenoid, subcoracoid, and subclavicular. In most common is subcoracoid. In posterior there are 3 types: acromial, subglenoid, and subspinous. In inferior it is infraglenoid dislocation.
So in anterior, what are the 3 things?
Subcoracoid, subglenoid, subclavicular.
All right. So till now you haven't diagnosed what it is, but you are suspecting an anterior shoulder dislocation. So the general inspection and all these things you have done. Right now moving into special tests for this thing.
Shoulder Dugas test is when you'll have to try touching the opposite shoulder. Normally we can touch the opposite shoulder, but in patients with dislocation they will have difficulty touching the opposite shoulder. And Hamilton ruler test will keep a ruler from olecranon.
So Dugas, Hamilton ruler, okay.
And axillary circumference.
Okay. So what about the Hamilton ruler? Dugas you have already mentioned.
Yeah.
Like this. Then Hamilton ruler.
From humeral head to the olecranon process we'll have to measure. Usually when we keep the ruler,
from here to here.
Usually it does not touch. The ruler will not touch both olecranon and humeral head. But in case of dislocation, there will be a straight line.
Okay.
And coming to axillary circumference will be...
So olecranon is more prominent there. So you're able to straight away connect olecranon with the what?
Humeral head to olecranon process.
Olecranon to humeral head.
And compared to the other hand, axillary circumference will be elevated in dislocation. Using a measuring tape, we can measure the axillary circumference.
Okay. Once more.
Axillary circumference, we'll have to measure using a measuring tape.
Okay.
It will be increased when compared to the other hand.
And
in
because of swelling.
dislocation.
Because of swelling.
Swelling and
Okay. So the Hamilton roller is from the olecranon till
humeral head.
humeral head.
So post which we
So
took an
it signifies that some dislocation is there. If it is positive.
positive.
And swelling, that's the circumference is just what is the purpose basically?
Dislocation, it comes out and the circumference will increase in anterior and posterior dislocations.
But you don't know whether you can't differentiate between anterior,
not
posterior,
an
or
100%,
inferior dislocation.
yeah.
You know that there is a dislocation. That's all.
That's all. Then we took an X-ray, AP lateral and scapular view of right shoulder.
Okay. So basically, like differentiating between the different types of dislocation is only possible by X-ray.
In
Or else that
AP view, we can only say whether there is a dislocation or not. Only in lateral, we'll get to know whether it's an anterior or posterior. So we took an X-ray and we got to know that it's an anterior dislocation, subcoracoid most probably. So we had taken consent for procedural sedation, for reduction under sedation. Consent was taken. We had connected chest leads, cardiac monitor, O2 was connected, crash cart was kept ready. Patient was given injection ketamine 50 mg IV stat and injection midas 2 mg IV stat. After 5 minutes, we had rechecked all the vitals and we used a modified Hippocrates method. In this method, one sheet is tied.
So this procedural sedation, Entonox is another thing that you can use, Entonox. But usually in UK, according to Arkham only they use it. We have used ketamine with midas. What dose?
Midas 2 mg IV stat and ketamine 50 mg.
So midas will act as a muscle relaxant, right? Okay, and that will calm down the patient also. And ketamine?
Analgesic, it will give both analgesic. Dissociative analgesia.
Anesthesia, okay. Not analgesia.
Anesthesia.
Okay. Ketamine is where is it contraindicated?
Increased ICP patient in ocular surgeries because it will increase IOP. Patient having tachycardia.
Okay. What dose did you give?
50 mg IV stat.
So ketamine given along with midazolam to prevent what? Why is it given together? Emergence phenomenon. Okay.
Then we went ahead with the modified Hippocrates method. In this method, one sheet is tied across the shoulder.
What are the various methods for reduction?
Modified Hippocrates, Stimson's method, Kocher's method, Cunningham method, and scapular manipulation technique and Milch technique.
Milch. So this can shoulder dislocation may come as a short note for you. So the various techniques are modified Hippocrates, Stimson's, Kocher's, Milch,
Cunningham.
So we have
used a modified
Hippocrates.
Here one sheet is tied across the shoulder and held by the assistant. Across the shoulder and
across the shoulder you just take a sheet.
This is
like
for
this.
counter
Patient
traction.
should be like around like 30 to 45 degree angle should be lying like that. And one sheet should be
tied around
and one person will be applying
counter
traction towards that direction. The other person will be applying counter traction on the upper elbow. Yeah.
So one more person, the physician will tie a sheet across the forearm, most probably near the elbow, and he'll start giving traction, and the assistant will give counter traction around the shoulder. Coming to Stimson's method, here the patient is made to sleep on a prone position with his affected hand hanging over the side of the bed.
Yeah, like this patient will be lying down.
And this affected hand will be hanging down. And it's connected to 7 to 10 kg weight. So and we have to wait for 20 to 30 minutes.
So slowly after some time, after some muscle gets relaxed, it will fall into
Reduction.
the place. That's called the
Stimson's
technique.
Couch's technique, patient should be made to sleep in a supine position. Affected shoulder should be adducted and kept. Elbow is flexed at 90 degree in the beginning. Then slowly the examiner will start rotating externally rotating the arm. Then slowly for around 1 minute so that the muscle will relax, and then he'll abduct the arm so that the humerus head will come back into the place.
Okay. External rotation followed by abduction. Once hand is like this.
First the adduction, then external rotation. Elbow should be flexed, external rotation, and then abduction.
But his hand is like this, no?
Yeah. After sedation, we'll have to adduct the arm. Then slowly externally rotate. Keep it for 1 minute so that the muscle will relax and come back to the position, and then externally rotate.
The first movement is external rotation, or?
We'll have to keep the patient in adduct position. Then movement is
but his hand is like this.
Yeah. Elbow flexed with adduction. Then we have to give traction with external rotation.
Okay.
Then coming to Mills technique, we'll have to abduct the arm fully and along with external rotation. Abduction, external rotation, slightly overhead abduction. This is the position of the patient. Now maintain this external rotation throughout the abduction. Whenever we are doing the abduction, we'll have to maintain the external rotation. Reduction, now it is achieved by applying gentle traction in line of the humerus. Our thumb will be around the humerus and will give slight pressure over the humerus so that muscle is relaxed and the humerus goes back to the glenoid process. Coming to Cunningham,
it's better you understand at least one technique thoroughly, because otherwise problem happens is you'll just try to come confused with all these manuals and you'll combine everything. That's a problem. So at least the modified Hippocrates. You understand? Okay.
In Cunningham technique, first we have to adduct and hold. Keep his hand. We'll have to keep adduct and hold and keep the patient's hand on your shoulder, physician's shoulder, and slowly massage biceps so that the muscle start relaxing. Then slowly, once the muscle starts relaxing, ask the patient to elevate or shrugging movement so that the humerus will go back to the glenoid cavity.
So the patient will keep your hand on the physician and you'll just start massaging.
Bicep massaging so that the muscle start relaxing and the.
Okay. And then ask to shrug like that. That's called the Cunningham method.
Shoulder joint is a type of ball and socket joint. It's an articulation between glenoid fossa of scapula and articular surface of humeral head.
Yeah. This is the humeral head, this is the glenoid fossa. Okay.
The factors responsibility for the stability are rotator cuff muscles, negative intra-articular pressure, and synovial fluid. And causes for this dislocation.
And the labrum is also here, which connects the glenoid cavity to the
humeral head.
On top of that, we'll have all the rotator cuff muscles. Okay.
These causes of shoulder dislocation are the shallowness of the glenoid cavity. It is not completely covered, and it has extraordinary range of movements and underlying any ligament laxity in old age people. In anterior dissection, usually it can be either a direct anterior dislocation can be a direct injury or an indirect injury. In indirect injury, fall on an outstretched hand with shoulder in abduction and external rotation. Direct injury is when anterior directed force from posterior shoulder. From behind, anterior directed force is given from behind. That is direct.
So these are the two mechanisms of
injury.
Injury in anterior dislocation. But in your case, it wasn't like that, no? It wasn't. It was like pushing a bike.
Manually pushing.
And then suddenly it got. Does he have a previous history of dislocation?
No, his previous history of dislocation.
But according to this mechanism, it's different. Injury from the front, like in that particular position, right? What is the position?
externally rotated and abducted, outstretched hand.
Outstretched hand, like that. Okay. Or it could be from the posteriorly.
Types, as we mentioned earlier, it's subcoracoid, subglenoid, and subclavicular. And now coming to pain management, different types of pain management we can
And does
use.
it really matter which subcoracoid and sub?
Most commonly 80% subcoracoid.
And does it really matter for us?
No, sir. But types will matter because with posterior and inferior, there can be other type of fractures associated with it.
Yeah, anterior, posterior, inferior. But that subclassification of anterior shoulder dislocation, I don't know. Like maybe some orthopedician will.
Not much of significant. Pain management can be done with NSAIDs, opioids, benzodiazepam, or you can also use intra-articular lidocaine injection. Around 10 to 20 ml of 1% lidocaine can be taken. After a sterile skin preparation, introduce the needle in the created space of that displaced humeral head. You can insert. Complications.
Lidocaine,
1%, 10 to 20 ml.
Into the space. Okay.
Coming to complications, recurrence, and there can be Hill-Sachs and Bunkart's lesions.
And you could have done that, no? You had given ketamine and you could have given lignocaine. So why didn't you give that?
Usually will.
It's not like that. For all these things, lidocaine and all, no, you need cardiac monitoring and the antidote also. 20% intralipid should be there. Because of you'll be trying to anesthetize that area and finally patient will land in all arrhythmias or seizure. Should have the antidote with you. So that's why it's better to use this one.
Coming to complications, lesions seen are Hill-Sachs lesions and Bunkart's lesion. Hill-Sachs lesion is seen when there is a dislocation, and Bunkart's lesion is seen when the post-reduction. If patient is having recurrent dislocation, reduction can cause Bunkart's lesion. Hill-Sachs lesion, posterior lateral defect.
So that means if the patient has got a Bunkart's lesion, that means patient already is a known case of recurrent dislocation. Okay.
Sorry, sir, I told it ulta. In Bunkart's lesion, it's due to dislocation. Hill-Sachs is due to reduction. Bunkart's lesion is avulsion of the labrum of the glenoid rim. That is due to the dislocation. Avulsion of the labrum. A Hill-Sachs lesion is posterior lateral defect caused by glenoid impression on humeral head. While doing reduction due to the impact of the humeral head on the glenoid, that is causing the Hill-Sachs lesion.
This can come as like a Markham SBA and all. It may come as one X-ray will be shown, identify the lesion. One scenario will be given, and they will say this is identify the lesion. Like lesions will be, the options will be Bunkart's lesion, Hill-Sachs lesion, reverse Bunkart's, reverse Hill-Sachs, like that. They won't say which dislocation actually. Posterior or anterior they won't mention, but they'll just show you the X-ray. Okay.
Other complications are vascular injuries, nerve injuries, and rotator cuff injuries, as mentioned earlier. Now coming to posterior dislocation, it is less common as compared to the anterior dislocation.
So how long you should wait before discharging this patient? Once reduction is done, you should ideally you should bring back the
and
your hands,
immobilize
like this. It has to be kept like that.
In a sling, always in adducted position.
Yeah, it has to be in a sling.
At least for 3 months or 3 weeks.
3 weeks. Okay.
And post-reduction X-ray is also very important.
So after that, you can ask him to review in orthopedics. OPD.
Coming to posterior dislocation, causes both indirect and direct force. Indirect is when forceful internal rotation and adduction happens. Direct is when direct blow to the anterior shoulder. Patient will come with adduction and internal rotation, and they will be unable to do external rotation and abduction. Here we can see reversed Hill-Sachs deformity, an impaction fracture of the anterior medial humeral head due to posterior dislocation. Coming to inferior dislocation, mechanism is hyperabduction injury. Patient comes with severe pain.
Posterior dislocation is commonly seen after a seizure episode.
In X-ray, we can see light bulb sign.
In posterior. So you should be careful whenever you get a sudden internal adduction and internal rotation can cause a posterior shoulder dislocation. So if after a seizure, if you are not careful enough to examine that part and you send the patient to the ward or something, and finally it turns out to be this thing that if you don't find it out at the right point, they can actually sue you. It's a medical legal problem. So always whenever you see a medical case like seizure, always see whether posterior dislocation is there or not. Okay. It's better to document that, like moving all limbs and everything.
Mechanism is hyperabduction
This is
force, inferior dislocation.
Subluxation. Basically, it's not dislocation, it's subluxation. Okay.
Patient comes with severe pain and upper limb will be held in hyperabduction.
Like this.
Usually, infraglenoid dislocations are seen.
So it is like going down, like that.
Most common nerve injuries are axillary and suprascapular nerve. Suprascapular will give supraspinatus and infraspinatus blood nerve supply. Vascular injuries are axillary injury. Coming to closed reduction failures and success. Success rate is more seen more in first time reduction, and if previous history of closed reduction.
How to reduce this thing, the inferior shoulder?
Inferior shoulder.
Are you dealing into that area or like sticking on to anterior shoulder?
Traction, we have to give upward traction, upward and outward traction. One person will be holding from this part, the other person will be holding from here, and upward and outward traction is given.
So complications of almost all the shoulder dislocations are almost the same, right?
Axillary.
All neurovascular issues. Posterior shoulder dislocation also? No, nothing more to how will you reduce?
Same as anterior.
Okay, some other day we'll discuss that.
Contraindication for dislocations are any vascular injuries, any other humerus fractures like surgical head of humerus fracture, greater or lesser intratrochanteric fractures. In such conditions, closed reduction should not be done. And failure rates are most commonly seen in elderly, and previous history of open reduction is seen. We are not supposed to do closed reduction this time. If previous history of dislocation and they have done open reduction, we are not supposed to do an closed reduction next time.
It means suppose some orthopedic procedures have been done in the past
Before.
for the same problem. Do not try to manipulate again and do the same thing. Okay. That's all.
Yes.
For OSCE station and all, usually shoulder examination as such will be kept. Patient will be complaining of shoulder pain and things like that, and you will have to assess the rotator cuff. All the muscles you will have to verbalize that I am checking the activity of
Passive and
active movements of supraspinatus, deltoid, infraspinatus, teres minor, all these things, and some special tests are also there. In this case, it is not possible because patient is in severe pain. Otherwise, in a normal OSCE station, that is what they keep. You'll be asked to do all those active, like special tests, including Gerber's lift-off sign and all these things. No, that Neer's test and the empty can test. All these things will have to be done. This usually comes as a short motor, anterior shoulder dislocation, posterior shoulder dislocation. That's all. Okay.